All right, let's dive right into one of the most critical topics in modern medicine, acute coronary syndrome, or ACS. Now, you probably know this condition by its more common name, a heart attack. What we're going to do here is build a complete, modern, evidence-based picture of how we diagnose it, how we manage it, and how our entire approach has evolved over the years. To really get a grip on where we are today, you've got to look back. And our story really starts way back in 1768 with a physician named William Heberden. He was the first to write down a clinical description of what we now call angina pectoris. But look at how he described it, a disorder of the breast. It just shows you how little was understood about the heart's role back then. For over a century, these symptoms were often blamed on anything but the heart. You can see this long, slow march of progress on this timeline. After Haberden's first description, it takes until 1912 for James Herrick to come along with this brilliant, groundbreaking idea, the coronary thrombosis theory. He proposed that a blood clot in the heart's arteries was the cause. But here's the kicker. His theory was largely ignored for decades. It wasn't until 1980, when a landmark study by Marcus DeWood provided the actual angiographic proof, the smoking gun, showing these acute clots in real time. That study changed everything and launched the modern era of reperfusion therapy. So all this new understanding led to a massive shift in how we even diagnose a heart attack. The old antiquated 2 out of 3 rule, based on symptoms, ECG, and enzymes, is long gone. It's been replaced by a much more rigorous and globally accepted framework, the 4th universal definition of myocardial infarction. This isn't just a suggestion, it's the standard, and it demands diagnostic precision. Let's break down what that means. The absolute foundation of the modern diagnosis is biochemical proof of myocardial injury. We're talking about cardiac troponins. But here's the crucial part. A single high troponin level is not enough to make the diagnosis. Lots of things like sepsis or kidney failure can cause a chronic elevation. What we absolutely must see is a dynamic change, a clear rise and/or fall in the troponin levels. That dynamic pattern, with at least one value above that 99th percentile, is what tells you an acute event is happening right now. So you can think of the diagnostic process like a simple 2-step formula. Step 1 is non-negotiable. You have to detect that acute myocardial injury using the troponin criteria we just discussed. But that's only half the story. Step 2 is you have to then connect that biochemical evidence to the clinical picture. You need to confirm that this injury is actually being caused by myocardial ischemia. So, what counts as clinical evidence of ischemia? Well, you only need to meet one of these 5 criteria. It could be the classic symptoms we all know, like chest pain or shortness of breath. It could be new, specific changes on the ECG, or it could be the development of pathological Q waves, which are a sign of irreversible cell death. Fourth, you could have imaging evidence, like an echo showing a new problem with how the heart wall is moving. And finally, the most direct proof of all, actually seeing the clot in the artery, either on an angiogram or at autopsy. Okay, so once you've made the diagnosis of a myocardial infarction, the universal definition helps us get even more specific. It stratifies MIs into 5 distinct types based on their cause. And this isn't just some academic exercise. This classification is absolutely indispensable in the clinic because it tells you why the heart attack happened, which in turn dictates the entire treatment strategy. Let's quickly run through these. Type 1 is your classic, textbook heart attack, caused by a plaque that ruptures or erodes, leading to a blood clot. But type 2 is completely different. This is an MI caused by a mismatch between oxygen supply and demand. Think of a patient with severe anemia or a crazy fast heart rhythm. The heart is working too hard for the amount of oxygen it's getting. And you can see why this distinction is critical, right? Treating a type 2 MI from anemia with powerful blood thinners meant for a type 1 MI would be inappropriate and potentially disastrous. Types 3, 4, and 5 cover more specific situations, like sudden death or MIs related to cardiac procedures. Now, let's focus on the most time-critical manifestation of ACS, the ST elevation myocardial infarction, or STEMI. The pathophysiology here is an acute, total, 100% occlusion of a major coronary artery. It's blocked off completely, usually by a big, fibrin-rich blood clot. Because of this, everything about STEMI management is governed by one simple, powerful principle. Time is muscle. And when we say time is muscle, we mean it literally. This number here says it all. After just 6 hours of a total coronary occlusion, only about 1/6 of the heart muscle that's in danger is still salvageable. The rest is likely gone forever. That 6-hour period defines our critical therapeutic window, and the clock is ticking furiously from the very first minute. To put that time is muscle principle into practice, we have extremely strict, guideline-mandated time targets, and the race against the clock begins the moment a patient makes first medical contact. From that point, the first target is this: get a diagnostic 12-lead ECG and have it interpreted in under 10 minutes. Everything else downstream depends on this first critical step. Okay, the ECG confirms a STEMI. If that patient arrives at a hospital that can perform a percutaneous coronary intervention, or PCI, the next clock starts. We call this the door-to-device time, and the target is to get from the diagnosis to having a guide wire across the blockage in the cath lab in less than 60 minutes. 1 hour, that's it. But what if the patient shows up at a hospital that can't do PCI? This is where a massive decision has to be made, and it's all about transfer time. The rule is this: can we get that patient to a PCI-capable center and have the wire cross the lesion in under 120 minutes from the initial diagnosis? If the answer is yes, then transfer is the way to go. But if that 120-minute window can't be met, we don't wait. We immediately give pharmacological reperfusion, clot-busting drugs called fibrinolytics, with a door-to-needle time of less than 10 minutes. So this leaves us with two main reperfusion strategies. Primary PCI is absolutely the preferred method. You're mechanically opening the artery, you're putting in a stent, it just achieves better blood flow with a lower risk of bleeding. However, and this is a huge however, fibrinolysis is an incredibly important, life-saving therapy when you can't get to PCI in a timely fashion. The data is clear. An early dose of a clotbuster provides a much better survival benefit than a delayed PCI. All right, let's pivot to the other major player in ACS, the non-ST elevation myocardial infarction, or NSTEMI. The pathophysiology here is different from a STEMI. Instead of a total blockage, you typically have a subtotal occlusion from a platelet-rich or white thrombus. Some blood is still getting through. Because of this fundamental difference, fibrinolytics, the clot busters, are a no-go. They don't provide any benefit and actually increase bleeding risk. So instead, our management paradigm shifts to a risk-stratified invasive approach. The timing of intervention in NSTEMI is precisely tuned to the patient's individual risk. For the sickest, most unstable patients, we're talking those in cardiogenic shock or with chest pain that just won't quit, they need an immediate invasive strategy. That means they're in the cath lab within 2 hours. For the majority of other confirmed NSTEMI patients, an early invasive strategy within 24 hours is the standard of care. Now, regardless of whether it's a STEMI or an NSTEMI, there are some medications we give immediately, right there in the acute setting. This is our initial pharmacological assault. We give a chewable, non-enteric-coated aspirin for rapid absorption. We give a loading dose of a potent P2Y12 inhibitor like clopidogrel or ticagrelor to hammer the platelets, and we give a high-intensity statin. The early statin is crucial, not just for its long-term cholesterol effects, but for its immediate anti-inflammatory and plaque-stabilizing properties. After the acute phase is over, the work is far from done. We transition to lifelong secondary prevention. This means aspirin and a high-intensity statin for life. It means dual antiplatelet therapy, or DAPT, for a guideline-directed period, which is typically 1 year. And, super important here, is the initiation of beta blockers and ACE inhibitors within the first 24 hours. These drugs have a proven survival advantage because they help prevent the heart from changing shape in a bad way, what we call adverse remodeling, which is a huge factor in long-term prognosis. So, we've successfully opened the artery, the patient is feeling better. You'd think the danger has passed, right? Well, not quite. Even with perfect, timely reperfusion, a myocardial infarction is a major injury to the heart muscle, and it can leave behind some very serious lingering threats. We generally categorize these post-infarct complications into 3 main buckets: hemodynamic, electrical, and mechanical. Let's break those down. Hemodynamic complications are basically pump failure, like cardiogenic shock. Electrical instability is when the heart's wiring gets fried from the injury, leading to life-threatening arrhythmias, like ventricular fibrillation. That's the #1 cause of sudden cardiac death. And finally, you have the mechanical catastrophes. These are rare in the modern era, but they're devastating things like a rupture of the heart's free wall or the septum between the ventricles. And all of this leads us to a really provocative concluding thought that I think defines the next frontier in cardiology. Our success with reperfusion strategies has been absolutely remarkable. We've drastically reduced the number of people who die from the acute event. But in doing so, we've created a new long-term challenge. So the question becomes, has the central focus of MI care shifted from just surviving the initial attack to a new battle,
managing the chronic damage to prevent that patient from developing heart failure down the road. This really represents a crucial paradigm shift for the future of cardiovascular medicine.